Hey guys, welcome to my YouTube channel. Let's revise medicos. I am Vaishnavi, a final year MBBS student, and today we are going to start with infectious diseases. To start with, chickenpox. Here we go. Chickenpox, also known as varicella, we'll study it under agent factors, host factors, complications, and management. Agent factors. The agent is varicella zoster virus, which is also known as human herpes virus 3. It is a type of DNA virus. Source of infection is a case of chickenpox and rarely a patient with herpes zoster. Virus is present in the oropharyngeal secretions and the vesicular fluid, which is present in the lesions of the skin and the mucosa. The lesions during first 3 days of illness. Scabs are, however, not infective. Infectivity period it ranges from 1 to 2 days before to 4 to 5 days after the appearance of rash, or we can say until all the vesicles are crusted. Secondary attack rate is high. It is 85%, may range from 61 to 100%. Host factors. Age of the host, usually children less than 10 years of age. However, the disease is also seen in adults and it presents a severe form. Immunity. The patient gets durable immunity. If occurs during pregnancy, the fetus is at risk for developing congenital varicella syndrome. Provided the infection occurs in the first 20 weeks of gestation, there is 0.4 to 2% chances of children getting affected. Also increases the risk of developing herpes zoster in the first years of life. The chickenpox disease, it peaks during winter and spring. Interepidemic cycle is of 2 to 5 years, and the virus it gets readily inactivated by lipid solvents, detergents and proteases. How does the disease transmit? Droplet infection and droplet nuclei via either upper respiratory tract or conjunctiva. Mostly, it is face to face contact, that is, personal contact. Also, may occur through transplacental transmission. The incubation period of the disease ranges from 14 to 16 days on an average. However, the range widely if accepted is 10 to 21 days. Clinically, the patient presents in two phases. First is pre-eruptive stage and second is eruptive stage. In pre-eruptive stage, there is sudden onset of mild or moderate fever, back pain, shivering, malaise, which lasts for 24 hours in children and 2 to 3 days in adults. Whereas in eruptive stage, there is appearance of rash. Appearance of rash is the first sign which can be clinically considered for diagnosis of chickenpox. However, in rash, the distribution is symmetrical. It initially presents on the trunk and then it spreads to face, arms, and legs. It is also present in axilla. However, it is absent on palms and soles. Density it decreases centrifugally. Normally, the number of lesions vary from 10 to 1500. On an average, 300 lesions are present in a person. The, the lesions evolve rapidly, that is, from macule to papule to vesicle to scab. What are vesicles? Vesicles are dewdrops or skin and they are not umbilicated. However, this evolution takes 4 to 7 days after the appearance of rash. That is, formation of scab takes 4 to 7 days after the appearance of rash. Chickenpox rash exhibits pleomorphism. What does that mean? All the stages, that is macule, papule, vesicle, scab, can be seen at a time in the same area in the same person. So, rash exhibits pleomorphism. Fever it is not high and it shows exacerbations with each crop. Mortality rate is less than 1%. However, it is associated with complications. Complications like hemorrhages, pneumonia, encephalitis, acute cerebellar ataxia, Rey syndrome, secondary bacterial infection, congenital varicella syndrome is seen. Pneumonia, most common complication in neonates, adults, and immunocompromised patients. Acute cerebellar ataxia generally appears after 21 days after the appearance of onset of rash. Congenital varicella syndrome includes fetal wastage, cutaneous scars, atrophied limbs, microcephaly, low birth weight, cataract, microphthalmia, deafness, and cerebral and cerebrocortical abnormalities. If the patient is immunocompromised, as an AIDS patient, it may also present with acute retinal necrosis or outer retinal necrosis. Also, it may present with DIC, that is disseminated intravascular coagulation, which can be fatal. So, what are the differential diagnoses? It can be any rash, it can be herpes simplex, enteroviral infection, that is foot, mouth, hand disease, or drug reactions. So, how do we manage the patient? First of all, lab diagnosis, prevention, and post exposure prophylaxis. In lab diagnosis, we do PCR for detecting the varicella zoster virus DNA or in cell culture. Samples are usually vesicular fluids, crust, saliva. Other specimens like CSF can also be considered. Direct immunofluorescence test has low sensitivity. Now, to control, that is for treatment, we give acyclovir, valcyclovir, famciclovir. We isolate the patient for 6 days after the onset of the rash, and we disinfect the surfaces. Acyclovir is given 20 milligrams per kg per dose, 4 doses in one day, continued for 5 days. And these doses are effective if given within 24 hours after onset of the rash. How to prevent? We give immunoglobulin, we give vaccine. Passive is by immunoglobulins, active is by vaccine. So, varicella zoster immunoglobulin, it is given within 72 hours of exposure. It is given as intramuscular injection with dose of 12.5 units per kg, maximum of 625 units to be given, and we need to repeat the dose in 3 weeks. It is used as a method of prevention in exposed individuals, in immunosuppressed patients, susceptible teens, pregnant women, newborn, and premature infants. Active immunity by vaccine. It is live attenuated vaccine. So it is first of all, it is live attenuated, so it is contraindicated in immunocompromised. It is recommended for children between 12 to 18 months who haven't had chickenpox. Another monovalent vaccine, it is given as a two-dose schedule, especially in children greater than 13 years of age. zero point 0.5 ml each given subcutaneously. Minimal interval between the two doses should be of 4 weeks to 3 months if the child is between 1 to 12 years of age, and 4 to 6 weeks if the child is 13 years or older. Another is combination vaccine, that is given with MMRV vaccine, given if the child ages 9 months to 12 years. Two doses with minimal interval of 4 weeks to be given. Duration of immunity is on an average of 10 years. Vaccines are contraindicated in people allergic to neomycin in pregnancy, and in the treatment course, we do not give aspirin or ibuprofen. Why? Because aspirin precipitates Rey syndrome, whereas ibuprofen does the same for necrotizing fasciitis. And pregnancy should be delayed 4 weeks post vaccination. Now, what is the post exposure prophylaxis? In unvaccinated healthy people aged more than 12 months, as soon as within 5 days post exposure to rash, unless if contraindicated, and efficacy if it is more than 90% if vaccinated within 3 days of the exposure. If all these conditions are satisfied, we go for post exposure prophylaxis. So what we have done the agent factors, which includes the agent VZV or HHV3, the source of infection, which is a case, or a patient with herpes zoster. Scabs are not infective, is to be remembered. Infectivity period is 1 to 2 days before the appearance of rash and 4 to 5 days after. Secondary attack rate is to be remembered. It is approximately 85%. Host factors, we need to remember it occurs usually in children. However, it may also occur in adults. Immunity, primary infection gives durable immunity. And what we need to remember is the incubation period, normally 14 to 16 days. However, the range is from 10 to 21 days. It occurs in two stages, pre-eruptive and eruptive. Pre-eruptive is with prodromal symptoms like fever, back pain, shivering, malaise. Eruptive stages, appearance of rash, which is symmetrical, appears initial in the trunks and spreads to face, arms, and legs. Number of lesions normally varies from 10 to 1500, average 2 to 300. The rash exhibits pleomorphism. Fever is not high, however, exacerbates with each crop. And the complications like hemorrhage, pneumonia, encephalitis, acute cerebellar ataxia, race syndrome is to be remembered, congenital varicella syndrome is to be remembered. Lab diagnosis is by PCR by detecting the VZV DNA or in cell culture. Treatment we give acyclovir, valcyclovir, famciclovir, especially if given within 24 hours after onset of rash, it is more effective. Prevention is by immunoglobulin vaccine. Vaccine is either live attenuated or monovalent or combination vaccine. And the number of doses. Immunoglobulin is given intramuscular 12.5 units, maximum 625 units within 72 hours of the exposure. And aspirin and ibuprofen is to be contraindicated, is to be remembered. So that's all with chickenpox, and it is useful in your pediatrics as well as your PSM exams. So it's more of a common subject. We'll cover up the next infectious diseases in the next further videos. Until then, keep revising.